Today we are focusing on pediatric gastrointestinal conditions, a topic the NCLEX loves to test through priority and assessment-based questions. Let's start with dehydration, the most common complication. The exam won't ask you to simply define dehydration. It will present a scenario and ask you to identify the most severe case. For an infant, the key signs are different than for an adult. You must look for sunken fontanelles, an absence of tears when crying, and a decreased number of wet diapers. A sunken fontanelle is a late and severe sign. If a question presents 4 children, the one with a sunken fontanelle and lethargy is your priority, not the one who simply has a history of vomiting. For fluid replacement, know that initial resuscitation is done with isotonic solutions like normal saline, not dextrose-containing fluids, which can worsen electrolyte imbalances. Now, let's discuss pyloric stenosis. The classic exam presentation is a male infant between 2 and 5 weeks old who develops sudden, forceful, non-bilious projectile vomiting right after feeding. A key distractor is regular spitting up or GERD, but the forcefulness is the giveaway. The infant will be hungry immediately after vomiting. The definitive assessment finding the NCLEX will expect you to know is a palpable olive-shaped mass in the right upper quadrant. Preoperatively, the nursing priority is correcting fluid and electrolyte imbalances. Postoperatively, you will reintroduce feeding slowly, starting with clear liquids in small amounts. Next is intussusception, where one part of the bowel telescopes into another. The exam will test your recognition of its unique presentation. Look for a child, usually under 2 years old, with sudden, intermittent, severe colicky abdominal pain. During these episodes, the child will scream and draw their knees up to their chest. Between episodes, they may appear completely normal. This intermittent nature is a trap. The problem has not resolved. The hallmark sign you must know is the passage of stools that look like currant jelly, a mix of blood and mucus. A sausage-shaped abdominal mass might also be palpable. The priority is to prepare for a diagnostic and therapeutic procedure, typically an air or barium enema, which can often resolve the issue without surgery. Let's also cover appendicitis. The key here is the progression of pain. It typically starts as a dull, periumbilical pain and then localizes to the right lower quadrant at McBurney's point. A common exam trap involves a sudden cessation of pain. This is not a sign of improvement. It is a critical red flag that indicates the appendix has likely ruptured, leading to peritonitis. This patient is now at high risk for sepsis and becomes the immediate priority. They will present with a rigid, board-like abdomen, fever, and tachycardia. Preoperatively, you should never apply heat to the abdomen as it can increase the risk of rupture. To help you remember the key signs of intussusception, think of the phrase, "The gut is in PAIN." P for pale skin during pain episodes, A for a palpable, sausage-shaped abdominal mass, I for intermittent, severe colicky pain with the child drawing their knees to their chest, and N for nausea and vomiting, which can lead to the classic currant jelly-like stools. Recognizing these signs is critical for identifying this abdominal emergency on your exam.